Welcome back to the deep dive. Today, we're taking a bit of a different approach. We've got this huge stack of clinical guidelines, really complex notes, and we're boiling it all down. Boiling it down to the precise high-yield stuff you actually need.
Exactly.
And this one's specifically for GP trainees gearing up for the AKT exam, focusing right in on geriatric medicine.
That really is the mission today, geriatrics.
Yeah.
It's tough, isn't it? You've got chronic conditions bumping up against acute problems, and, well, the safety margin is just so thin in older patients.
Right.
And for the AKT, it's not just about knowing, say, pneumonia. You have to recall the exact numbers, the cutoffs, the age thresholds, the criteria that mean stop, change plan, admit now.
Yeah, the things that make the difference between managing at home and getting them straight into hospital.
Precisely. So we're aiming for efficient, actionable knowledge, turning all that data into clear clinical commands you can use under pressure.
Okay, so the sources we're using today, it's a curated pile, basically. Clinical notes covering everything from, the quick acute stuff, CURB 65, head injuries, right through to managing chronic diseases, thinking about polypharmacy, safety, the works.
Think of it as the AKT geriatric cheat sheet, maybe. But, properly explained.
Yeah, something like that. A shortcut to synthesizing the absolute must-know guidelines.
And the big picture here, running through everything we discuss, is clinical safety and actionability. Making those calls in primary care. Who needs admitting for CAP? Who needs that urgent head scan after a fall? They're high stakes, huge consequences.
Absolutely.
So understanding these precise criteria helps you make those calls fast, confidently, and crucially for the exam, correctly.
Yeah.
So shall we jump into those acute scenarios?
Let's do it. Okay, starting with a really common one, especially in winter. Suspected community-acquired pneumonia, CAP. You mentioned risk stratification is key in the elderly, and that means CURB 65, right?
Straight to CURB 65. It's your rapid-fire tool for assessing mortality risk. And for the AKT, you must know the numbers for each letter. No ambiguity.
Okay, break it down for us. C.
C is for confusion, but it's specific. It means an abbreviated mental test score, AMTS, less than 8. If they score 8 or more, even if they seem a bit muddled, they don't get the point for C.
Right, strictly AMTS less than 8. Okay, what about the U, the lab results?
U is for urea. Needs to be greater than 7 millimoles per liter. This is a big one because, in an older person, high urea often flags up significant dehydration, maybe kidney issues, severe infection, signs that the body is under major stress, poor prognosis marker.
Got it.
R is respiratory rate. It has to be a 30 breaths per minute or higher. That points towards significant respiratory compromise. They're working hard to breathe.
Okay. And B, blood pressure.
Yep. B is blood pressure, looking for hypotension here. So systolic pressure under 90 millimeters of mercury or diastolic pressure 60 or below. Either of those counts.
Under 90 systolic or 60 or less diastolic.
Yeah.
Okay. And the last one's easy.
The 65 is just age. 65 years or older gets the point. Simple as that. So each of those 5, C, U, R, B, 65, scores 1 point if present.
Okay, so we've got the components, the exact numbers. But you said the real crunch point for the exam is knowing what the score actually means for management. Where do we treat them?
Spot on. That's the practical translation. If the patient scores 0 or 1, the mortality risk is low. Generally safe to manage them in the community. First-line antibiotic, simple amoxicillin.
Amoxicillin for 0 or 1. Okay. What about score 2?
Score 2, the risk bumps up a bit. Community management might still be okay, but we need stronger antibiotic cover. We escalate to dual therapy, amoxicillin plus clarithromycin. Adding the macrolide is key at score 2. That's a common trip-up point.
Right. Adding the clarithromycin at score 2.
Right.
And then the critical threshold, the score that means get them in.
The absolute line in the sand is a score 3 or higher. 3, 4, or 5, that patient needs immediate hospitalization. No debate. And the drug regimen changes again, too. Broader cover needed. So it's co-amoxiclav plus clarithromycin. That's step-up amoxicillin, then amoxicillin plus clarithromycin, then co-amoxiclav plus clarithromycin plus admission. That's fundamental geriatric safety, highly testable, cannot fudge that score of 3.
Crystal clear. Okay, shifting gears from infection to trauma. Acute head injuries in the elderly. We know they're higher risk after a fall, even a simple one. Something about brain atrophy and bridging veins.
Exactly. Age-related brain shrinkage stretches those bridging veins, making them much more prone to tearing and causing subdural hematomas, even with minor trauma. So our sources really highlight specific mandatory CT criteria for patients 65 and over.
Mandatory. So this isn't optional.
No, this is where age changes the game completely. For someone 65 or older, just watching and waiting often isn't good enough if certain red flags are there. You must order an immediate CT head if they're 65 plus and they have confusion or memory problems that are still going on more than 8 hours after the injury.
8 hours is the cutoff for persistent confusion.
Okay. What about the fall itself? Does the mechanism matter?
It does. If the fall was from higher than 1 meter, or specifically down more than 5 steps that warrants imaging, it's a surprisingly low threshold for what counts as a significant mechanism in this age group.
1 meter or 5 steps?
Yeah.
Got it. And loss of consciousness?
Yes. If there was LOC, loss of consciousness, that lasted more than 8 hours, you scan them. Again, that 8-hour mark.
And the really big one for primary care, the thing that trumps almost everything else.
Anticoagulants. This is probably the most critical GP point. Any patient, 65 or over, who is on warfarin or any DOAC, apixaban, rivaroxaban, dabigatran, idoxaban, they must have a CT head if their head injury symptoms persist beyond 8 hours or if they have specific neurosigns.
Regardless of how minor the knock seemed.
Regardless, the risk of a delayed bleed, especially a sneaky subdural, is just too high to monitor them at home if they're anticoagulated. It's non-negotiable. Scan them. Okay. Anticoagulant status equals mandatory scan if symptoms 8 ARFs or neurosigns in the over 65s. Right. Let's quickly touch on a couple of other acute markers with specific numbers. Hypothermia. What do we see on the ECG?
Yes, the hypothermia ECG. Initially, the classic sign you look for is the Osborne J wave. It's that little positive blip at the junction of the QRS complex and the ST segment.
The J wave. But is there a critical temperature?
There is. The number to remember where things get really dangerous, cardiac-wise, is 22 degrees Celsius. If the core temperature drops to 32 degrees or below, that's when you start seeing the really nasty stuff, profound bradycardia, different types of heart block, life-threatening arrhythmias.
32 degrees, okay. And switching to, again, UTIs, we try not to overtest, but when is getting a midstream urine and MSU absolutely required? 3 groups.
3 specific groups where you must send an MSU for culture. First, pregnant women, always. Risk complications is high, and you need that test to cure. Second, children. And third, our focus group today, patients over 65. Why? Because their UTI symptoms can be really weird or masked, or they just present with delirium. You need that culture to be sure what you're treating and that it's gone afterwards. Over 65, get the MSU.
Makes sense. And once you've diagnosed a UTI, say in someone elderly, we need to think about antibiotic safety, especially with kidney function. Nitrofurantoin and trimethoprim are common, but there are EGFR restrictions.
Massive safety point. Absolutely critical for AKT. You must avoid both nitrofurantoin and trimethoprim if the patient's EGFR is less than 45. Full stop. Avoid below 45.
Why is that?
Well, nitrofurantoin just doesn't get concentrated enough in the urine to work effectively if kidney function is poor. And trimethoprim can accumulate and cause toxicity, especially hyperkalemia. So less than 45, avoid.
Okay. Is there any wiggle room? What about slightly better kidney function?
There's a little gray area. If the EGFR is between 30 and 44, you can use them, but the guidance says with caution and only for a short course, defined as 3 to 7 days maximum. Longer courses are out. That specific threshold, EGFR 45, is vital for safe prescribing in the elderly.
Okay, EGFR 45 is the key cutoff for nitro-trimethoprim. Avoid below, caution 30-44 for short courses only. Got it. Hashtag check tag 3. Chronic management guidelines tied to age cutoffs. Right, let's move into chronic management. This is where age, history, and specific scores like T-scores really dictate treatment, often in quite complex ways. Osteoporosis treatment thresholds, this always feels like a guideline minefield.
It can seem like it, but we can simplify it by focusing on the absolute triggers. There are 3 specific scenarios where you start alendronic acid, which is the usual first choice, pretty much automatically, without even needing a general DICXA scan result first.
Okay, automatic triggers. What's scenario 1?
Scenario 1. Steroid-induced osteoporosis. If someone's on long-term steroids, you do a DICXA and their T-score is minus 1.5 or lower, you start alendronic acid right away. Note that threshold, minus 1.5. It's higher, less negative than the usual osteoporosis threshold because steroids themselves add significant risk.
Minus 1.5 T-score on steroids means treat. Okay.
Right.
What are the other automatic triggers, maybe more related to age?
Scenario 2. The patient is 65 or older, and they've been taking daily prednisolone for 3 months or more. That combination, age over 65, plus significant steroid exposure, means you treat prophylactically. Don't wait for a fracture or a degassing.
65 plus, on pred for 3+ months. Treat. Okay, scenario 3.
Scenario 3. The patient is 75 or older, and they've already had a fragility fracture. So an older patient who has already proven their bones are fragile, the risk of another, possibly worse, fracture is just too high, you start treatment.
75 plus with a previous fragility fracture previous, right? Those are the 3 automatics. What about the general population threshold if none of those apply?
The general trigger, for anyone really, is if the T-score on DEXA is less than -2.5. That defines definite osteoporosis according to the WHO, and treatment is indicated.
T-score less than -2.5. Okay.
Yeah.
But you mentioned a difference for younger patients.
Yes, this is a key distinction, often tested. If the patient is under 65 and doesn't fit the steroid criteria, you need to be a bit more cautious. You must do the DAXA first, obviously, but you only start alendronic acid if their T-score is -1.5 or lower. So for younger patients, we're using that tighter threshold, similar to the steroid-induced one, to be sure before committing them to long-term treatment. We want to rule out secondary causes, too.
Ah, okay. So under 65, its T-score exweighs a con at 1.5 to treat after DEXA, 65 plus on steroids for 3-meter treat, 75 plus with fracture treat, steroid-induced treat if T-score is 1.5, and general population treat if T-score -2.5. That clarifies the layers.
It's that layering T-score plus age plus risk factors like steroids or previous fracture that guides the decision, not just the T-score alone.
Right.
Got it. Okay, let's pivot to the heart. Valvular heart disease, VHD. Focusing on aortic stenosis, AS, our notes say the cause often depends on age, and that then dictates the type of replacement valve used.
Yes, exactly. It's a neat link between pathology and treatment. In older patients, say over 65 typically, the main cause of AS is just wear and tear degenerative disease, calcification of the valve leaflets.
Makes sense. And in younger patients?
In younger folks under 65, while degeneration can happen, a much more common underlying cause is a structural issue. They were born with a bicuspid aortic valve, meaning 2 leaflets instead of the normal 3. That leads to abnormal flow and earlier stenosis.
Okay, so cause relates to age, and when surgery is needed, valve replacement, the choice between mechanical and biological valves, that hinges on age and anticoagulation tolerance.
Absolutely. For the elderly patient, the strong preference is usually for a bioprosthetic valve made from pig, porcine, or cow bovine tissue. Why? Because although they don't last forever, maybe 10, 15 years typically,
they crucially avoid the need for lifelong warfarin. The anticoagulation plan for a bioprosthetic valve is much simpler. Aspirin for life, yes, but warfarin only for the first 3 months after the operation, just to cover the initial healing phase when clot risk is highest.
Aspirin lifelong, warfarin just for 3 months. Okay? And for the younger patient needing a valve.
If they're younger and likely to outlive a tissue valve, then a mechanical valve is often preferred. These things are incredibly durable, they can last a lifetime. But the trade-off is mandatory, lifelong, strict anticoagulation with warfarin, and that means regular INR blood tests forever.
Lifelong warfarin. And those INR targets are different depending on which valve was replaced. That sounds like prime AKT territory.
Absolutely non-negotiable numbers to know. If they had an aortic valve replacement, AVR, the target INR is 3.0.
INR 3.0 for aortic.
But if they had a mitral valve replacement, MVR, the mitral position is inherently more prone to clot formation. So the target INR needs to be higher for better protection. The target INR for MVR is 3.5.
3.5 for mitral. Okay, 3.0 aortic, 3.5 mitral. Essential detail. Right, moving to glands. Endocrinology. Subclinical hypothyroidism. A very common query in primary care, slightly high TSH. Patient feels maybe okay, maybe a bit tired. Do we treat or watch?
Yeah, it's a classic GP dilemma. The guidelines are quite cautious, especially about starting treatment in older adults because, giving too much thyroxine can carry risks, particularly cardiac risks like AF. So the main treatment rules focus on patients under 65.
Okay, so under 65 is first. When do we definitely treat?
If the patient is under 65 and their TSH comes back at 10 or higher, you treat. That's a clear indication, TSHU 10.
TSH 10 or more, under 65, treat. What about that gray zone TSH between, say, 5.5 and 10?
If the TSH is in that intermediate range, 5.5 to 10, and the patient is clearly symptomatic and they are under 65, then you can consider a trial of treatment. It's a consider. But if they're asymptomatic, or crucially if they're 65 or older, the default approach is usually just to monitor. Repeat the TSH periodically, maybe every 6-12 months. Unless the TSH really climbs way above 10, you generally hold off initiating treatment in the over 65s. That age cutoff acts like a brake.
Okay, so under 65. Treat if TSH consider TSH 5.510 and symptomatic. Over 65. Generally monitor unless TSH is very high or very symptomatic. That simplifies it. Good. Right. Public health time, vaccinations, and screening the age checklist. AAA screening.
Abdominal aortic aneurysm screening. Very specific. It's a one-off ultrasound scan offered routinely only to men when they turn 65.
Just men at 65.
Just men at 65 routinely. Women are generally only screened if they have specific high-risk factors like a significant smoking history or maybe a very high cardiovascular risk score like QRS suggested, but not routine for women.
Okay. And the usual jabs for the over 65s. Flu, shingles, pneumococcal.
Yep, standard stuff. Annual flu jab every autumn for everyone over 65. Shingles vaccine, they become eligible, usually around 65 or 70, depending on the program specifics, check local guidance. And the pneumococcal vaccine, PPV-23 usually. That's typically given once when they turn 65, and for most people, one dose provides enough protection long term.
One dose of pneumococcal, usually enough. Okay. COVID jabs.
Currently, the guidance for COVID boosters is focused on the most vulnerable. So it's generally people over 75 who are offered it twice a year, a spring booster and an autumn booster.
Over 75s, spring and autumn. Now, the sources mention a new vaccine cohort for RSV. This sounded a bit fiddly with dates, high yield potential.
Ah, yes, respiratory syncytial virus. This is new and likely testable because the eligibility is quite precise. Okay, the main group is adults who turn 75 on or after the 1st of September 2024.
Turn 75 on or after 1st, 2024.
Correct. And they remain eligible to get the vaccine up until their 80th birthday. But there's also a catch-up group to cover those who are already in that high-risk age bracket. So, adults who are already aged 75, 76, 77, 78, or 79 on the 1st of September 2024 are also eligible for a catch-up dose.
Right. So current 75, 79-year-olds as of Sept 1st, 2024 get a catch-up, and new 75-year-olds from that date onwards are eligible until they're 80. Precise dates matter.
Very precise. Get those dates wrong in an AKT scenario, and you'll get the answer wrong.
Okay, duly noted. Last bit on chronic care kidney function. Renal failure follow-up. We monitor EGFR and ACR. The timing of repeating the EGFR seems to depend on how much it dropped and how quickly.
Exactly. You need to distinguish between an acute drop and chronic decline. If you check someone's kidney function and find a first-time reduction in their EGFR of more than 15 points compared to their previous baseline,
more than 15 drop,
that suggests something acute might have happened. Maybe they got dehydrated, started a new drug like an NSAID, had an infection. Because it could be serious and potentially reversible, you need to repeat the blood test quickly within 2 weeks.
Repeat in 2 weeks for a 15 drop.
Okay.
And if it's just a slow, steady decline over time, chronic kidney disease.
If it's a known chronic reduction or a smaller drop, the standard protocol for stable CKD monitoring is usually to repeat the kidney function tests, including EGFR and ACR, every 3 to 6 months, depending on the stage. Let's say 3 months as a general rule for stability. The faster follow-up is for that potential acute crisis.
Makes sense. And we should probably quickly recap the actual CKD classification, the GNA stages. It dictates risk.
Yeah, good idea. It combines the glomerular filtration rate, G stage, with a level of albuminuria, A stage. The G stages relate directly to the EGFR number. G1, ESHRCR 90, normal or high. G2, EGFR 60-89, mildly decreased. G3A, EGFR 45-59, mild, moderate. G1 down to G5, moderate, severe. G4, EGFR 15-29, severely decreased. G5, EGFR 15, kidney failure.
G1 down to G5, and the A stages based on ACR.
Oh, stages are based on the albumin to creatinine ratio ACR in NG-mol. A1, ACR3, normal to mildly increased. ATR 330, moderately increased, formerly macroalbuminuria.
A1, A2, A3. So knowing someone is, say, G3BA3 tells you they have moderate severe kidney damage and significant protein leak, which drastically increases their cardiovascular risk and affects things like ACE inhibitor use.
Precisely. It's the combination that paints the full risk picture.
Okay, moving on to those big geriatric syndromes, the things that really represent functional decline, which we spend so much time managing in primary care. Let's start with falls and frailty. Obviously, a history of previous falls is the biggest risk factor, but what about medications? Any specific drug classes to flag up?
Well, polypharmacy itself is a huge risk, obviously. The more drugs, the higher the risk. But specific culprits, definitely sedating drugs. So things like codeine, other opiates, benzodiazepines, they just increase drowsiness and unsteadiness.
Sedatives.
And also drugs that cause orthostatic hypotension, a drop in blood pressure on standing. Many drugs can do this, but our notes specifically flag levodopa for Parkinson's disease. It's well known for causing postural drops, especially when starting or increasing the dose, leading to dizziness and falls.
Levodopa specifically for postural drop risk.
Okay. And if someone is falling, what's actually the most effective intervention, according to the evidence? Is it just stopping heads?
Surprisingly, while medication review, the Stop PP Start tools we'll mention later, is vital, the single most impactful intervention is actually structured exercise. Specifically, programs that include strength and balance training, aiming for around 150 minutes a week.
Exercise and balance training, 150 mins week, more effective than just stopping drugs.
Often, yes, unless there's one really obvious culprit drug. But improving strength and balance gives them more resilience against falling.
Right. Now, frailty assessment. We try to be objective. There's the Prisma 7 questionnaire, which is useful. But what about that physical measure, gait speed? What's the actual cutoff time?
Yeah, gait speed is a simple but powerful predictor. You time them walking a set distance, usually 4 or 5 meters. If it takes them more than 5 seconds to walk 5 meters, that's generally considered indicative of frailty.
More than 5 seconds to walk 5 meters. That's a clear functional marker. It really is. Predicts falls, hospitalization, mortality. A simple but very useful test.
Okay, let's shift to the cognitive side of things, starting with delirium. It often gets confused with other things, especially maybe adjustment disorder if someone's acutely distressed after a life event. What's the absolute key differentiator for delirium?
The non-negotiable feature of delirium is the fluctuation in the level of consciousness or attention. GCS might go up and down. They might be drowsy one minute, agitated the next. It's acute onset, fluctuating course, often accompanied by perceptual disturbances like hallucinations or a disturbed sleep-wake cycle.
Fluctuating consciousness. And the risk factors are classic geriatric ones.
Exactly. Age over 65, definitely.
Yeah.
A big change in environment, like coming into hospital, polypharmacy. And then any acute physical illness. Infection, UTI, chest, pain, constipation, dehydration, electrolyte imbalance. The list is long. Remember the I's. Infection, inflammation, intoxication, impaction, iatrogenic.
Right, so how does that contrast with adjustment disorder?
Adjustment disorder is primarily a mental health response. Someone's had a significant stress of bereavement, retirement, maybe a scary new medical diagnosis. They're distressed, maybe low mood, anxious, not coping well. But crucially, their level of consciousness, their GCS, remains stable. It doesn't fluctuate like in delirium. And usually, there's no prior history of severe mental illness. If that consciousness level is bouncing around, think delirium first.
Stable GCS in adjustment disorder, fluctuating in delirium.
Yeah.
Got it. Okay, so you suspect delirium, you're treating the underlying cause, but what if they're very agitated? We need to be careful with drugs, especially if they have Parkinson's.
Extremely careful. This is a major safety point. For general agitation and delirium, you might consider low doses of antipsychotics like haloperidol, olanzapine, or perhaps quetiapine. However,
Big however.
Haloperidol and most older antipsychotics are potent D2 receptor antagonists. They block dopamine. In someone with Parkinson's disease, that can be catastrophic, massively worsening their rigidity, tremor, and bradykinesia.
So haloperidol is generally out if they have Parkinson's.
Generally best avoided, yes. Safer options for psychosis or agitation in someone with PD and delirium are usually the atypical antipsychotics, quetiapine or maybe olanzapine, though olanzapine can have anticholinergic effects. And if you need rapid sedation for severe agitation, lorazepam, a short-acting benzodiazepine, is often the preferred choice.
Quetiapine, olanzapine, lorazepam are safer in PD. Good to know. And what about sundown syndrome? Is that just delirium?
It's related but distinct. Sundown syndrome, or sundowning, refers specifically to that pattern of increased confusion, agitation, and restlessness that occurs in the late afternoon or evening. It's typically seen in patients who already have underlying dementia.
Ah, so it's a feature of dementia, worse in the evening.
Exactly. While delirium can happen anytime, sundowning has that characteristic evening worsening. Management is mainly non-pharmacological, trying to maintain a calm routine, good lighting during the day, reducing noise in the evening, maybe looking at social prescribing activities. Drugs are really a last resort.
Okay. Let's dive deeper into specific dementia subtypes. Lewy body dementia, LBD. There's a classic triad of symptoms for this one.
Yes, the LBD triad is key for spotting it clinically. First, fluctuating cognition. Big swings in attention and alertness from day to day or even hour to hour. Much more pronounced fluctuation than in Alzheimer's.
Fluctuating cognition. Okay, number 2.
Second, features of Parkinsonism. So Motor symptoms like rigidity, slowness of movement, bradykinesia, maybe a tremor, these often appear relatively early in LBD.
Parkinsonism. And third,
Recurrent, well-formed visual hallucinations. Patients often see animals or people that aren't there. These hallucinations are typically quite detailed. So fluctuating cognition, Parkinsonism, and visual hallucinations, that's your LBD triad.
got it. And we need to be careful with certain drugs again here, like with delirium and PD.
Absolutely. LBD patients are notoriously sensitive to antipsychotics, especially typical ones. They can cause severe worsening of Parkinsonism or profound sedation. Also, drugs that block dopamine, like metoclopramide, the anti-sickness drug, must be avoided as they can trigger or worsen LBD symptoms. Diagnosis is mostly clinical, but sometimes a specialist might order a SPECT scan, a DAT scan, to look at dopamine transporter levels.
Avoid antipsychotics and metoclopramide in suspected LBD. Okay. What about frontotemporal dementia, FTD? What's the big clue there?
The biggest clue for FTD is often the age of onset. It typically presents earlier than Alzheimer's, often in people under 65. So think younger onset dementia.
Under 65 onset, and the symptoms are different too.
Very different. FTD affects the frontal and temporal lobes primarily, so you see less of the memory loss typical of early Alzheimer's. Instead, you get marked changes in personality and behavior, things like disinhibition, saying or doing inappropriate things, apathy, loss of empathy, compulsive behaviors, or sometimes progressive problems with language. Memory might be relatively preserved initially.
Personality and behavior changes, often younger onset. That's FTD. Okay, finally, the most common one. Alzheimer's dementia, AD. Anything genetic we need to know?
Most AD is sporadic, late onset, but about 5% is inherited, early onset familial AD. There are specific genes involved. Mutations on chromosome 21 affecting the amyloid precursor protein, APP, or on chromosome 14, presenilin 1, PSEN1, or chromosome 1, presenilin 2, PSEN2. Also, the apolipoprotein E, ApoE gene, particularly the E4 allele, is a major risk factor for late onset AD. But you probably don't need to know the chromosome numbers, just that there are genetic links.
Okay, genetic links exist. More importantly, for the GP trainee, the MMSE score and the treatment algorithm, how do the scores dictate which drug to start?
Right. The mini-mental state examination score is crucial here for guiding initiation. The algorithm basically splits based on severity. If the AD is severe, defined by an MMSE score of less than 10.
MMSE less than 10.
You generally start memantine. Memantine works differently from the other main drugs. It's an NMDA receptor antagonist. It's the primary choice for severe AD.
Memantine for severe, MMSE 10. Okay. What about mild or moderate AD?
For mild to moderate AD, which is defined as an MMSE score between 10 and 24, you start with one of the acetylcholinesterase inhibitors. These aim to boost acetylcholine levels in the brain.
And those are the DRG drugs.
Exactly. The mnemonic helps. D for donepezil, R for rivastigmine, G for galantamine. You typically start one of these.
Donepezil, rivastigmine, galantamine for mild, moderate, MMSE 10-24. Any key side effects to watch out for, maybe specifically with donepezil as it's common?
Yes, donepezil, like the other cholinesterase inhibitors, can cause gastrointestinal upset. Nausea, diarrhea are common. But also watch out for insomnia and, importantly, bradycardia or heart block. Because it increases cholinergic activity, it can slow the heart rate. So caution is needed, maybe an ECG before starting, especially if they have pre-existing heart issues.
Bradycardia heart block with donepezil. Good point. And generally, in anyone with dementia, are there medications we should actively try to stop?
Definitely. Good medication review is vital. You should look to stop drugs with strong anticholinergic effects, as they can worsen confusion. Things like amitriptyline, certain bladder drugs, oxybutynin. Lithium needs careful monitoring if used, and antipsychotics should only be used if absolutely necessary for severe distress or psychosis, and reviewed regularly, aiming to stop if possible due to the increased risks, including stroke and death, in dementia patients. #V, medication safety and metabolic emergencies.
That leads nicely into medication safety overall. Polypharmacy is such a huge issue in geriatrics. What are the formal tools we actually use in practice to try and rationalize complex drug lists?
There are two main tools designed to be used together that are really helpful. First is the SOPP tool, that stands for Screening Tool of Older People's Prescriptions. It helps you identify potentially inappropriate medications that should probably be stopped because the risks outweigh the benefits in an older person.
SOPP helps you stop things.
Yeah.
Okay. And the other one?
The other is the START Tool Screening Tool to alert doctors to right treatment. This one works the other way around. It helps you identify potentially beneficial medications that the patient isn't currently taking but maybe should be, based on their conditions, things like anticoagulation for AF or bone protection.
START helps you start things. So So PP and start together for a full medication review.
Exactly. One looks for drugs to remove, the other for drugs to add. It provides a structured way to optimize prescribing.
We've talked about drug safety in Parkinson's and LBD a couple of times. Can we just quickly reinforce the drugs to avoid in PD and the safer options again?
Absolutely. Key message. Avoid drugs that block D2 dopamine receptors. That includes most traditional antipsychotics, like haloperidol, and also the antiemetic metoclopramide. They will worsen Parkinson's motor symptoms.
Avoid D2 blockers like haloperidol, metoclopramide. Safer options for psychosis or severe agitation in PD?
Safer options are generally quetiapine, often first choice due to lower motor side effect risk. Potentially olanzapine, though watch for anticholinergic effects, or lorazepam for short-term sedation if needed.
Quetiapine, olanzapine, lorazepam, safer in PD. Got it. And that really specific SSRI dose restriction for citalopram in the elderly, that feels like a classic safety question.
It is, and it's based on MHRA guidance. Due to the increased risk of QTC interval prolongation on the ECG, which can lead to dangerous heart rhythms like torsades de pointe. If the patient is over 65 years old, the maximum licensed dose of citalopram is strictly 20 milligrams per day. You cannot go up to the usual 40 milligram dose in someone over 65. Same applies for citalopram, max 10 milligrams if over 65.
Max 20 milligrams citalopram if over 65. Max 10 milligrams citalopram. Okay, crucial dose cap. Right, last thing in this section, metabolic emergencies and diabetes. How do we tell the difference between hyperosmolar non-ketotic state, HONK or HHS, and diabetic ketoacidosis, DK? They can both present with confusion and high sugars.
They can look similar initially, but the underlying biochemistry is very different, and that's key for diagnosis. HONK, or hyperglycemic hyperosmolar state, HHS, as it's often called now, is more common in type 2 diabetes. The patient is incredibly dehydrated, often very confused or reduced GCS, maybe reporting extreme thirst. Their blood glucose is usually sky high, often over 30 or 40 millimole. But the defining feature is the absence of significant ketones and acidosis.
So HONK, HHS equals massive glucose, dehydration, confusion, but no ketones, no acidosis.
Essentially, yes. They still produce just enough insulin to prevent fat breakdown to ketones, but not enough to control the glucose. So urine ketones might be absent, or just trace 1 plus blood ketones low, pH normal or near normal, osmolality is very high.
Okay. And DKA, more common in type 1.
DKA is the classic type 1 emergency, though it can happen in type 2 sometimes, especially during illness. Here, there's an absolute lack of insulin, leading to massive ketone production from fat breakdown. So the diagnostic criteria are about meeting specific thresholds. Blood ketones greater than 3.0 millimole. Urine ketones 2 plus or more. Blood glucose is high, usually over 11 millimole, though can be lower sometimes, euglycemic DKA. And crucially, evidence of metabolic acidosis, bicarbonate level low, for your G15, and blood pH less than 7.3.
DKA equals ketones 3, blood or 2 plus, urine, glucose 11, pH 7.3. It's the ketones and the acidosis that really define DKA.
Exactly. Presence versus absence of significant ketosis and acidosis is the fundamental difference between DKA and HONKHAs, #86, high-yield diagnostic snapshots, AKT buzzwords.
Okay, final stretch. Let's do some rapid-fire diagnostic snapshots, the kind of classic presentations or triads the AKT loves to throw at you in vignettes, starting with Parkinson's disease medication choice when levodopa versus something else.
Simple rule of thumb often cited. If the Parkinson's symptoms are significantly affecting the patient's quality of life or their functional ability, the gold standard is to start levodopa. If the symptoms are still mild and not really impacting their daily life, you might start with a dopamine agonist instead, like ropinirole or pramipexole, especially in younger patients, to delay levodopa side effects. But function affected. Think levodopa.
Function affected, levodopa. Okay, Scheidegger syndrome. Sounds ominous.
It is. Scheidegger is a form of multiple system atrophy, MSA. The buzzword cluster is severe autonomic dysfunction, really bad postural hypotension, maybe erectile dysfunction, incontinence plus Parkinsonism, rigidity, bradykinesia, plus often cerebellar signs like ataxia, problems with coordination. It's that multi-system involvement, especially the prominent autonomic failure that points towards MS-Ashey-Drake.
Autonomic failure plus Parkinsonism plus cerebellar signs.
Right.
Normal pressure, hydrocephalus, NPH. The classic triad.
Ah, yes. The unforgettable triad for NPH is often summarized as wet, wobbly, and wacky. Clinically, that translates to urinary incontinence, wet, gait disturbance, typically a magnetic shuffling gait, difficulty initiating walking, wobbly, and cognitive impairment, often memory loss or slowed thinking, wacky. See those three together, especially in an older person, NPH is high on the differential. Needs imaging, usually CT or MRI, showing ventriculomegaly.
Wet, wobbly, wacky, incontinence, gait problems, memory loss. Okay. What about vertebrobasilar ischemia? How might that present in a vignette?
Often presents with dizziness or vertigo, but crucially, usually accompanied by other brainstem or cerebellar signs, things like double vision, slurred speech, swallowing problems, ataxia, or specific neurological signs on examination. A typical scenario might be persistent dizziness in an older adult, and the exam findings mention things like nystagmus, past-pointing dysmetria, or difficulty with rapid alternating movements, dysdiadochokinesia. Dizziness plus these localizing signs points towards a posterior circulation TIA or stroke.
Dizziness plus localizing neuroscience like dysmetria. Got it. Acoustic neuroma.
The classic picture is unilateral, gradually progressive sensorineural hearing loss. So hearing getting worse just in one ear over months or years, often accompanied by tinnitus in the same ear. Sometimes balance problems too, maybe linked to neurofibromatosis type 2. An exam question might give you tuning fork results like Weber test lateralizing away from the affected ear, confirming sensorineural loss. Unilateral sensorineural hearing loss and investigate for acoustic neuroma. MRI is definitive.
Unilateral progressive sensorineural hearing loss plus tinnitus. Okay. Moving to the gut. Volvulus causing large bowel obstruction. What's the X-ray sign?
The pathognomonic X-ray sign for sigmoid volvulus, the most common type, is the coffee bean sign. You see a massively dilated loop of sigmoid colon rising up out of the pelvis, looking like a giant coffee bean, caused by the twisted loop.
Coffee bean sign, volvulus, ischemic colitis. What's the typical setup?
Think of a patient with a risk factor for throwing clots, most commonly atrial fibrillation, AF. They suddenly develop acute, often crampy, abdominal pain, typically left-sided, followed relatively quickly by rectal bleeding, often described as dark red or maroon. AF plus acute abdominal pain plus rectal bleed equals suspect ischemic colitis.
Yeah.
Investigation. CT angiogram can confirm compromised blood supply.
AF plus abdo pain plus rectal bleed. Angiogram to confirm. Okay. Rhabdomyolysis, muscle breakdown. What happens to the electrolytes? Which go up, which go down?
Rhabdo releases intracellular muscle components into the blood. So things that are high inside muscle cells go up in the blood. That's primarily creatine kinase, CK, often massively elevated, potassium K+, and phosphate, PO4. Things that get consumed or shifted go down. That's primarily calcium, K day, it gets deposited in damaged muscle, and sometimes magnesium, Mg. So up CK, K plus D, PO4. Down.
Up C, KK, PO4. Down CO, Mg. Got it. Abdominal aortic aneurysm, AAA, rupture the clinical picture.
Classic presentation is sudden onset of severe abdominal pain, often radiating to the back or groin in someone with a known AAA or risk factors, older male, smoker. Crucially, often accompanied by signs of hemodynamic compromise, low blood pressure, tachycardia, collapse. Abdo pain plus low BP in someone at risk, suspect ruptured AAA. It's a surgical emergency.
Abdo pain plus hemodynamic compromise, increased ruptured AAA. Okay, pressure ulcers, quick review of the grades, Waterloo or EPU-AP classification.
Generally 4 main grades reflecting depth of tissue damage. Grade 1, intact skin with non-blanching redness. The skin hasn't broken, but there's damage underneath. Grade 2, partial thickness skin loss involving the epidermis, dermis, or both. Looks like a blister or a shallow crater. Grade 3, full thickness skin loss involving damage to or necrosis of subcutaneous tissue, but not extending through the underlying fascia. Looks like a deep crater. Grade 4, full thickness skin loss with extensive destruction, tissue necrosis, or damage to muscle, bone, or supporting structures, like tendons. Bone and tendon is visible or directly palpable.
1, redness. 2, shallow crater blister. 3, deep crater to fat. 4, down to bone muscle. And management basics.
Key principles are relieving pressure, keeping the wound clean, and managing exudate. Often involves using dressings that maintain a moist wound environment, like hydrocolloids or hydrogels, depending on the wound. Routine swabbing isn't recommended unless there are clear clinical signs of infection, spreading redness, pus, increased pain.
Moist environment, no routine swabs. Okay. And one last snapshot, post-operative cognitive dysfunction, POCD. How long can that linger?
Yeah, it's important to remember POCD can be quite prolonged. The sources suggest it can persist for up to 6 months after a major operation or hospital admission. So if an older patient is still complaining of brain fog or memory issues several months after surgery, it could well be POCD.
Can last 6 months. Good to know. Hashtag tag7R. Outro and final thought. Wow, okay. We have covered a lot of ground there. But hopefully, by really zeroing in on those specific numbers, the precise criteria, the exact drug choices or doses, it makes it more manageable. The goal was always efficiency and safety for decision-making, which is really what the AKT is testing.
Absolutely. And it's worth remembering, these numbers aren't just for passing an exam. They're the boundaries that guide real clinical action every day. That CURB65 score of 3 means hospital. That INR target of 3.5 for a mitral valve prevents a stroke. That eGFR of 45 stops you causing drug toxicity. They translate directly into safer patient care.
Well said. Okay, to wrap up, as always, we like to leave you with a final thought, something to mull over, connecting today's clinical focus to longer-term planning and patient wishes. Let's think about advance directives, or living wills. If a patient makes a legally binding advance directive to refuse life-prolonging treatment, what's the specific legal requirement regarding witnesses for that refusal to be valid in England and Wales?
Good question. For an advance directive refusing life-prolonging treatment to be legally binding, it must be in writing, signed by the patient, if capable at the time, and crucially, it must be signed in the presence of a witness who also signs it. Oh, wait, actually, let me double-check that. My apologies. For refusal of life-prolonging treatment, the requirement is actually stricter. It needs to be signed by the patient and witnessed by 2 people. 2 witnesses for refusal of life-prolonging treatment.
2 witnesses. Okay, that specific number is key for its legal validity. Important detail. And one final, very practical regulatory point every GP trainee needs embedded in their brain, linking clinical care back to function and safety in the community. DVLA driving license rules for older drivers after the age of 70. How long is a driving license issued for at a time?
After 70, drivers need to renew their license every 3 years, no longer the 10-year standard. Every 3 years after 70, ties everything back to that ongoing assessment of fitness to drive in our older population.
3 years. Another key number, right? You have the numbers, the criteria, the red flags. Hopefully this deep dive helps you nail that geriatric component of the AKT. Thanks for joining us.